Hi everyone, welcome to NURS 2020 Advanced Pathophysiology and Microbiology. In this lesson we're going to be continuing Unit 1, all about the blood and cardiovascular disorders, with a specific focus on the disorders of the heart. Here in Part 2 of the cardiovascular disorders, we will examine the various types of arrhythmias such as atrial fibrillation and ventricular tachycardia. And then we'll move on to look at endocardial, myocardial, and pericardial diseases, which are diseases that affect the various coverings of the heart. Finally, we will be discussing ischemic heart disease and coronary heart disease, or coronary arterial disease, CAD for short, which is a huge topic naturally. And lastly, we'll close off this lesson by discussing the two types of heart failures, left-sided and right-sided heart failure. Please remember to read this particular slide deck as well as look at all the other learning resources that are posted on the Blackboard shell. Just a little bit of review about ECGs. So in a normal ECG, the heart rate is about 50 to 100 BPMs. Tachycardia would be a heart rate above that, and bradycardia would be a heart rate below that. You also, as a nurse, have to examine the pattern of the ECG. Is it regular, which is defined by equal RR or PR intervals between the heartbeats? That's what we would refer to as normal sinus rhythm. Or is it an irregular rhythm, for example, as in atrial fibrillation? We'll also discuss the various escape rhythms, such as the atrial escape rhythm in the case of sinoatrial node failure. In that case, if the SA node is not functioning properly, the AV node will take over, but in that case, the heart rate will drop because the AV node intrinsically fires at a lower rate. So now the heart rate will drop from the regular 50 to 100 to about 60 to 80 beats per minute. If both the SA and AV nodes have become dysfunctional, then the Purkinje fibers, or the conduction system in the heart, in the ventricles rather, to be more precise, will take over, and so now you have a ventricular escape rhythm. In that case, the heart rate will drop even further. Bradycardia is going to be significant with a heart rate of 20 to 40 beats per minute. Long before then, a pacemaker will have to be implanted. Let's start off with normal sinus rhythm. In normal sinus rhythm, the heart rate is between 60 and 100 beats per minute. It has a regular rhythm, so the PP interval or the RR intervals are regular, and all the other intervals, such as the PR and QT and QRS intervals, are also of normal durations. You can see examples of a normal sinus rhythm. The top example is an actual ECG rhythm strip, lead 2, and the bottom one is a simulated. I have a program that simulates various ECG rhythms, and you can see what normal sinus rhythm would look like. It's regular, the intervals are all of normal duration, although it's not indicated over here, and this represents normal sinus rhythm, or NSR for short. In the case of sinus tachycardia, you have an abnormally fast heart rate that is greater than 100 beats per minute. The SA node is firing far faster than normal. Typically, this is a compensatory response to a reduced cardiac output, for example, in shock, which we'll be discussing in Part 3. So here you can see the RR intervals and the PP intervals have all decreased, so you have a much faster heart rate. Here's an actual ECG rhythm strip, and here's a simulated ECG rhythm strip. The ECG machines usually calculate the heart rate and displays it. You can see here the actual heart rate is 121 beats per minute, which represents sinus tachycardia. In sinus bradycardia, the heart rate is lower than 60 beats per minute. Please note, however, that this might be normal if the individual is really aerobically fit. The PP and RR intervals are much greater than normal, as represented by the ECG rhythm strips shown here. Let's move on to atrial fibrillation and atrial flutter. Atrial fibrillation is a completely disorganized and irregular atrial rhythm that is accompanied then, subsequently, by an irregular ventricular rhythm. It, in fact, is the most common sustained arrhythmia. The risk factors for atrial fibrillation are as follows. Non-modifiable would be age, modifiable would be hypertension, heart failure, valvular heart disease, recent cardiac surgery, lung disease, as well as excessive alcohol consumption, and sepsis, for example, a complication of pneumonia. The clinical manifestations of atrial fibrillations are palpitation, fatigue, dyspnea, dizziness, or syncope. If you look at the ECG rhythm strip shown at the bottom over here, you will see that in atrial fibrillation, you have multiple P waves, hundreds of P waves that make the baseline look very irregular. That's what atrial fibrillation is. You can also see it in this diagram over here, whereby the baseline looks very jaggedy, and that's because you have multiple P waves. That's atrial fibrillation. Atrial fibrillation itself may precipitate or exacerbate heart failure. And most importantly, atrial fibrillation is a very important risk factor for the development of a stroke or other thromboembolic events. In fact, individuals with atrial fibrillation are typically on anticoagulation therapy, for example, warfarin therapy, in order to reduce the risk of thromboembolic events. For example, the development of a pulmonary embolism. In the case of ventricular tachycardia, you have the definition of 3 or more consecutive ventricular complexes at a rate greater than 100 beats per minute. Usually the rate is 140 to 200 beats per minute. In the ECG, you see a series of very large, wide QRS complexes. So overall, it looks like very large, wide waves that you're seeing. The P waves themselves are not typically associated with the QRS complexes, and because of the large, wide QRS complexes, the P waves are not even identified over there. In the case of ventricular tachycardia, it has to be managed very quickly, otherwise it can prove to be fatal. It can progress to ventricular fibrillation and cause eventual death. For ventricular fibrillation, it is the rapid chaotic arrhythmia that results ultimately in the ventricular quivering, not beating, just quivering, and essentially you have a lack of any contraction whatsoever. So the heart is quivering, but it's not really doing an effective contraction. No blood is actually being pumped out of the heart itself, and there's only no identifiable QRS complexes over there. Ventricular fibrillation is a terminal event unless ACLS is promptly initiated in order to maintain proper ventilation and cardiac output. ACLS stands for Advanced Cardiac Life Support. Ventricular fibrillation, or VFib, is the most frequent cause of sudden cardiac death. And yes, as you know, the treatment is electrical defibrillation. If you look at the examples of the ECG shown here, it is complete chaotic electrical impulses over here. There are no identifiable P waves and certainly no identifiable QRS complexes as well. And so this is a terminal event, and ACLS protocol has to be activated, CPR needs to be started, and electrical defibrillation initiated as well. Let's move on to discuss various conduction abnormalities, starting with the AV blocks. So remember from your A&P, there's a slight delay at the atrioventricular node before the electrical signals can pass from the atria into the ventricle. So here we have normal sinus rhythm, everything's working perfectly. The pacemaker is the SA node, then it passes through the AV node, slight delay, in order to allow for the atria to contract and push a little bit more blood into the ventricles, and then it goes into the ventricles where then you have the QRS complex, and then the ventricles relax, and you have this T wave, which represents ventricular repolarization. But if the AV node becomes dysfunctional for whatever reason, you have these so-called AV block rhythms, starting with a first-degree AV block. In a first-degree AV block, the conduction signal is slowed down even more significantly at the AV node. So there's usually a slight delay at the AV node. In the case of the first-degree AV block, the delay is longer. That is manifested by an increased PR interval. So if you look at normal sinus rhythm, you can see the PR interval is here. It's about 2 small square boxes. Here in the first-degree AV block, you have a much longer PR interval. It's only more than 2 small square boxes, and that represents a slowing down of the signal going through the AV node, the electrical signal going through the AV node, the action potential, to be more precise, going through the AV node. So that's a first-degree AV block. In the case of a second-degree AV block, you can see it starts off with what looks like a normal P wave, QRS complex T wave, normal PR interval, and now the PR interval increases. So this one's been increased, and then suddenly it increases even more, and then there is no transmission of the electrical signal through the AV node, and consequently no activation of the Purkinje fibers, no QRS complex. So the AV node slows down even more, slows down even more, and then it doesn't go through the AV node at all, and so you have a missed beat. You literally have a missed heartbeat. And then everything goes back to normal. And then again it slows down, and slows down even more. And then you miss a beat. So this is a second-degree AV block whereby the signals through the AV node slows down and slows down and slows down even further, and eventually doesn't go through, and then the cycle repeats itself. If you notice, it's a form of bradycardia because the heart rate slows down. The computer doesn't see that missed beat. Well, it isn't there. And so when it calculates the average of the heart rate, you can see it's lower because you've missed a beat here, you've missed a beat there. In the case of third degree AV block, now you have no passage of the action potential through the AV node. So there's a complete separation of what's happening in the atria and the ventricles. So there's no correlation between the P waves and the QRS complexes. The Purkinje fibers take over themselves, and you can see the rate drops even further. 50 might be a bit optimistic. It drops down typically to 20 to 40 beats per minute because the Purkinje fibers beat at a much lower intrinsic rate. So there's no relationship between the P waves and the QRS complexes. They are more or less beating to their own rhythm, so to speak, over there. So here's one P wave, here's another P wave, here. There's no relationship to the QRS complexes, whereas in normal sinus rhythm, the P wave always precedes the QRS complexes. Here, it's completely disjointed, it's completely separated, there's no relationship over there. But the Purkinje fibers have taken over, so the heart rate has slowed down, and in this case it does show a regular rhythm. It's just a much lower heart rate. In the case of third degree AV block, a pacemaker will have to be implanted because you can survive for prolonged periods of time with such a low heart rate. Right? That's just not going to be feasible. That's it for the various arrhythmias. We just covered the main ones, specifically atrial fibrillation, ventricular tachycardia, ventricular fibrillation, as well as the various AV blocks. Let's move on to talk about the diseases of the heart itself, starting with the disorders that affect the various layers of the heart. We'll begin by examining various endocardial diseases over there. So, starting with infective endocarditis, or IE for short. Infective endocarditis is an infection and inflammation of the endocardium, which is the innermost lining of the heart. Most commonly, it affects the valves because the valves themselves are made up of the endocardium. And the result is that you have vegetation on the leaves of the valves. The valves, the little cups of the valves are called leaves, and consequently what you see are referred to as leaflet vegetation. It's actually not vegetation in the sense that you have plants growing on your valves. What you have are thrombi and white blood cells and bacteria all clumped up together and deposited on the leaves of the valves themselves, and we call that vegetation. The etiology of infective endocarditis is bacterial in nature, so typical bacteria include S. aureus, other Streptococcus, and Enterococcus bacteria. The clinical manifestation of IE are, yes, it is an infection, and it is a fairly severe infection, so there are systemic manifestations including fever, chills, weakness, and weight loss, as you would anticipate for a more serious infection, generalized infection. The specific cardiac clinical manifestation include dyspnea, chest pain, murmurs of the heart valves, and signs of congestive heart failure as well if the infection and inflammation becomes far more severe. Lastly, because you have these vegetations growing on the leaves of the valves, they can become dislodged, and now you have various embolic events that can occur. For example, petechiae over the legs, and other focal neurological signs as the emboli get travel through the brain, for example, and splenomegaly as well. So that's infective endocarditis. Rheumatic heart disease, or rheumatic fever, is an acute inflammatory disease that follows infection with a group A beta-hemolytic streptococci. In this particular case, the antibodies against the normal streptococcal antigens that have infected us now get deposited in the heart, typically on the valves themselves, and now damage the connective tissue in the heart, but then it can progress to be deposited in other places in the body, including the joints as well as the skin. So it becomes a systemic disease. Rheumatic heart disease is most prevalent in children, so they get strep throat, sore throat, and fever. Typically that resolves itself, but then a couple of weeks later, rheumatic fever and rheumatic heart disease develops. And so this is a form, as we'll see later on, of a type 3 hypersensitivity reaction where the antigen-antibody complexes get deposited in the joints, the skin, and yes, the heart, and cause inflammation in those locations and ultimately damage to those structures, including for the heart itself. Moving along to myocarditis, which is a form of myocardial disease. So the myocardium is the muscular layer of the heart. It's made up of cardiac muscle as opposed to smooth muscle or skeletal muscle. In the case of myocarditis, it is inflammation of the myocardium that can range from acute to chronic, and as we'll see, it is an important cause of dilated cardiomyopathy. So if you have a singular episode of myocarditis, it might not lead to other forms of cardiomyopathy, but multiple episodes of myocarditis can lead to dilated cardiomyopathy. The etiology of myocarditis could be idiopathic. Sometimes there's no identifiable cause. It could be infections, most commonly a viral infection. It could be a toxic insult like ingesting illicit drugs such as cocaine. It could be a complication of chemotherapy. It could occur from an adverse drug reaction, various antibiotics, diuretics, lithium for the treatment of bipolar disorders. It could also be a complication of several other systemic diseases such as systemic lupus erythematosus or rheumatoid arthritis. So myocarditis is a serious infection and inflammation of the heart, and consequently you do anticipate constitutional symptoms such as fever, fatigue, malaise, chills, and so forth. But myocarditis can progress to acute heart failure, and we'll be discussing heart failure shortly as well. As the myocardium becomes inflamed, you can anticipate that the individual, the client or patient will experience chest pain, which can be variable, all the way from mild to fairly severe. The progression of myocarditis can ultimately then result in various arrhythmias, including lethal ones such as ventricular fibrillation. And lastly, another complication of myocarditis could be the development of a pulmonary embolism. We briefly mentioned how myocarditis could progress to dilated cardiomyopathy. Let's discuss cardiomyopathies then. Here's a normal outline of the heart, whereby you have the atria over here, the ventricles, normal ventricular wall thickness. Almost certainly the left ventricular wall is thicker than the right ventricular wall. But in the case of cardiac myopathies, you can see there are three forms: dilated, hypertrophic, and restrictive cardiomyopathy. In dilated cardiomyopathy, the chambers are all dilated compared to normal. In hypertrophic cardiomyopathy, the ventricular wall have hypertrophied. In this case, the left ventricular wall and the intraventricular septum have hypertrophied. They become much thicker than normal. In the case of restricted cardiomyopathy, the myocardium has thinned a little bit, but mostly it's been replaced by connective tissue. So it's not the normal contractile heart muscle. Now you have connective tissue that is not contractile. It doesn't expand and contract like normal muscle fibers over there. So we're not going to focus anymore on the various cardiomyopathies. Just know the definitions of them, know that the types of them: dilated, hypertrophic, and restrictive cardiomyopathy. Most of these are genetic diseases, and that's why we're not going to focus upon the etiology itself, because it is genetic in nature. Either that or autoimmune as well. So just very briefly, dilated cardiomyopathy, you can see it's usually idiopathic. Perhaps it's initiated by a viral infection. The clinical manifestations typically present as heart failure because the chambers have enlarged so much, so pressure is not being generated adequately. Cardiac output is affected. There's a risk of the development of pulmonary embolism because the chambers are much larger. There's blood stasis, and anytime you have blood stasis, you have the risk of development of a thrombus and an embolus. Various arrhythmias can also develop, and that in turn can lead to sudden cardiac death. In the case of hypertrophic cardiomyopathy, it is a genetic defect involving a sarcomeric protein. The clinical manifestations are mainly in terms of diastolic dysfunction, shortness of breath on exertion, angina, syncope, congestive heart failures, and various arrhythmias, not unlike that of dilated cardiomyopathy. The complications, also like dilated cardiomyopathy, could be the development of various arrhythmias, specifically atrial fibrillation or ventricular tachycardia, and ultimately the progression to sudden cardiac death. Lastly, restrictive cardiomyopathy, you have impaired ventricular filling, and that's because of the increased fibrosis and replacement of normal cardiac muscle tissue by connective tissue, so you also have reduced compliance. The etiology could be infiltrative, so it's really what causes the connective tissue to infiltrate the cardiac muscle tissue. No one really knows, but it could be various conditions such as amyloidosis or sarcoidosis, or various other autoimmune diseases such as scleroderma. The clinical manifestations, just like the other forms of cardiomyopathy, are congestive heart failure, usually this time with preserved systolic function, so it's the diastolic function that is mainly affected, development of various arrhythmias, elevated jugular venous pressures, and the risk of the formation of various thromboembolic events, such as pulmonary embolism. Moving along to the outermost layer of the heart, the pericardium. Pericarditis is the inflammation of the pericardium. In terms of etiology, it could be idiopathic, which is the most common. It's presumed to be initiated by a viral infection. It could be infectious caused by a bacteria. Pericarditis could also develop after an MI, after cardiac surgery, during the course of uremia, when you have severe acute kidney injury, or even the end stages of chronic kidney disease, and as a complication of various neoplastic disorders. The clinical manifestations of pericarditis is that classic diagnostic triad of chest pain, a friction rub, and ECG changes, specifically ST elevation. Normally when you see ST elevation in the ECG, you think of a myocardial infarction, but you also see ST elevation in the case of pericarditis. So that's the triad: chest pain, a friction rub, and ST elevation in the ECG. Typically, clients with pericarditis will also complain of pleuritic chest pain. So this is chest pain that is worse upon breathing, and is typically elevated by sitting up and leaning forward over there. And that's because the pericardium is inflamed, and yes, it is innervated, and when you're breathing, the pericardium is right next to the pleural lining, and that's going to irritate it some more, and that's why you have this pleuritic chest pain. Pericarditis could also present with a fever, but sometimes not as well, right? So it just depends upon how severe it is. So fever and malaise and other constitutional symptoms may or may not be present. Moving along to pericardial effusion. So pericardial effusion is the excessive accumulation of fluid in the pericardial space. Normally there is some fluid over there. As the heart contracts, it just slides in the pericardium. It has to. But in this case, there's excessive fluid accumulation over there. In terms of the etiology, the fluid could be transudative in nature. So if it's serous, meaning mostly watery, that could be due to congestive heart failure or hypoalbuminemia, whereby you're altering the capillary exchange processes. It's all about the balance between hydrostatic forces and osmotic forces. So it could be that. In the case of congestive heart failure, you have venous congestion, and that increases the hydrostatic pressure. In the case of hypoalbuminemia, could be due to liver disorder, you have reduced oncotic pressure. In both cases, you have more fluid being pushed out of the capillary and less fluid being pulled back in, and so that's transudative in nature. That excess fluid could accumulate in the pericardial space. If it is exudative in nature, that could be sanguinous or bloody. Here you would have some sort of trauma to the blood vessels, or it could be a post-MI myocardial rupture or aortic dissection. You have blood, or at least a tinge of blood, pooling in the pericardial space. The clinical manifestations of pericardial effusion are similar to that of acute pericarditis. You have the classic triad of chest pain, friction rub, and ECG changes, specifically the ST elevation. In addition, there might be dyspnea and cough as lung functioning is impaired. And when the nurse auscultates the heart sounds are going to sound fairly distant as the fluid is surrounding the heart. The biggest complication of pericardial effusion is that if it is massive, it can lead to cardiac tamponade. Tamponade is when you have the rapidly accumulating fluid in the pericardial space, and that leads to high intercardial pressure, which decreases the venous return. That in turn results in a decreased preload, decreased cardiac output, hypotension, and ultimately venous congestion as well. So the big issue is that cardiac tamponade completely affects the functioning and the ability of the heart to contract, resulting in a decreased cardiac output and significantly decreased blood pressure, severe hypotension. The clinical manifestations of cardiac tamponade are tachypnea, dyspnea, and muffled heart sounds that we would anticipate, but the classic clinical manifestations are the so-called Beck's triad of hypotension. Hypotension is because of the decreased cardiac output that we've just explained, the increased jugular venous pressure as venous congestion sets in, and the muffled heart sounds as all the fluid surrounds the heart. That's called Beck's triad: hypotension, increased JVP, and muffled heart sounds. Cardiac tamponade might ultimately lead to obstructive shock as so much fluid and pressure surrounds the heart. Now cardiac output essentially plummets completely and shock results. And more specifically, obstructive shock because although the heart might still be functioning properly, it can't contract because of the increased pressure surrounding it. So the heart muscle itself is fine, but because of the pressure around it, the severe pericardial effusion, the cardiac tamponade, now blood cannot be ejected from the heart. So we call that a form of obstructive shock. We're going to switch gears completely and now move on to ischemic heart disease. Ischemic heart disease is the most common cause of cardiovascular morbidity and mortality. Certainly in the US, it's the second leading cause of death in Canada after cancer. Coronary heart disease, or CHD, and coronary arterial disease, CAD, are more or less synonyms of each other, and it's the most common form of ischemic heart disease. So ischemic heart disease is when the heart muscle, the heart itself, is not receiving enough oxygenated blood supply, and that is typically due to coronary arterial disease, or CAD. Alternatively, you can refer to it as coronary heart disease. I think most folks will refer to it as CAD, or coronary arterial disease. Atherosclerosis and thrombosis are the most common pathogenic mechanisms for CAD. So when you have coronary artery disease, what is causing a reduction in the delivery of oxygenated blood to the myocardium? It is atherosclerosis and or thrombosis. Remember, the thrombosis typically develops because of the rupture in the atherosclerotic plaque. In terms of epidemiology, it's a 2-to-1 male to female ratio for all groups, but if you look at individuals under the age of 40, it's an 8-to-1 ratio male to female. Whereas in the case of individuals above the age of 70, it's 1-to-1. So there's definitely some protective factor occurring in the case of younger females, and that is, yes, estrogen. So estrogen helps to protect the heart. Premenopausal women have a much lower risk of developing coronary artery disease and ischemic heart disease, and that's all because of the effect of estrogen. Post-menopause, when estrogen concentration decreases, you can see now the risk is approximately 1-to-1. Coronary heart disease incidence in women triples shortly after menopause, as we mentioned, due to the fact that estrogen concentration plummets. The peak incidence of ischemic heart disease, coronary heart disease, and coronary arterial disease is 50 to 60 in men and 60 to 70 in women, where you have to wait typically after menopause for the risk to increase greatly. The risk factors for ischemic heart disease are the risk factors for atherosclerosis and the same risk factors for coronary arterial disease. The non-modifiable risk factors are age, male sex, postmenopausal female, a family history of myocardial infarction, a family history of coronary artery disease. So there's not much you can do about that. Really, nothing you can do about that. The modifiable risk factors that a nurse could provide health education on is hyperlipidemia, so for example statin drugs to lower the concentration of LDL cholesterol and increase the HDL, the so-called good cholesterol, promoting adequate blood pressure control, so treating hypertension, promoting adequate and good blood glucose level control, so adhering to all the medication regimen for diabetes mellitus, taking the insulin properly, and overall just controlling blood glucose levels. As you probably know, diabetes mellitus is classified as an endocrine disease because it's a lack of insulin production, at least type 1 and later on in type 2. But really, diabetes mellitus is a cardiovascular disorder because the long-term complications are all micro and macrovascular in nature. Smoking is the other modifiable risk factor, as is abdominal obesity, heavy alcohol intake, and a diet that is poor in fruits and vegetables. Here's coronary artery disease in a schematic form. So it starts off with atherosclerosis, then you have acute plaque changes. The atherosclerosis also reduces the size of the lumen, leading to myocardial ischemia, and that leads to chronic ischemic heart disease. Sometimes it can just straight progress to sudden cardiac death if the intrinsic conduction system of the heart is affected. Let's assume not. So in the case of atherosclerosis, the plaque could rupture, change, and now you develop a thrombus over there. So now you have coronary coronary artery thrombosis. That leads to increased severity of ischemia of the myocardium, increase in terms of duration as well, and ultimately, if it's severe enough, it could progress to a myocardial infarction with actual loss of the cardiac muscle, and if the intrinsic conduction system is affected as well, you can have the development of various arrhythmias. If the infarct heals itself, it can still progress to chronic ischemic heart disease, because now one part of the heart has become permanently ischemic and healed, but it is fibrotic, and the other parts of the heart could still be affected in terms of ischemia over there. Also, and this we're not going to focus upon, as the infarct heals, you get remodeling of the heart. Normally you think remodeling is a good thing, but in this case it isn't, because the remodeling is typically done with connective tissue rather than cardiac muscle tissue. Cardiac muscle tissue does not regenerate itself. So ventricular remodeling is a bad thing, really, and only exacerbates the ischemic heart disease. The heart also tries to compensate by undergoing hypertrophy, but that itself is not good. It's like a form of cardiomyopathy. You don't want to dilate or hypertrophy the chambers too much, because that's going to increase the workload of the heart itself, or increase the volume of the chambers, neither of which is good. So chronic ischemic heart disease can ultimately then progress to congestive heart failure. These days medical professionals are just trying to call it heart failure rather than congestive. We'll explain why. But that's one of the key etiologies of heart failure, is chronic ischemic heart disease. But chronic ischemic heart disease can bypass heart failure completely and just lead to sudden cardiac death as well, especially if various lethal arrhythmias such as ventricular fibrillation develops. Here's examples of diagrams that illustrate atherosclerosis, because we know atherosclerosis is one of the etiologies for coronary arterial disease. So we have mentioned this briefly previously, but let's look at it again. So in atherosclerosis, you have some sort of initial injury to the blood vessel. Who knows what that injury is? Now you have the recruitment of various white blood cells, fatty streaks get deposited, macrophages ingest the fat, you form these so-called foamy cells, the lipid core gets deposited over there, and then all that is capped off, right? So here's the fibrous cap. So this looks like a fairly vulnerable plaque because the cap is very thin, as opposed to over here, where despite the fact that the overall stenosis, the overall narrowing of the lumen is greater than in this case over here, still you would much prefer to have this stable plaque with a narrow lumen rather than this unstable plaque with a wider lumen over here. So it's stable because the fibrous cap is a lot thicker over there, right? The unstable or vulnerable plaque is far more ominous because it can rupture and trigger the formation of a thrombus. So if you look at the diagrams on the right, you can see the formation of a thrombus over here. Here's the fatty plaque, and here the plaque has ruptured for whatever reason and a thrombus has formed. You have 100% occlusion over there, and that can lead to, for example, a myocardial infarction. Over here you can also see a plaque has ruptured over here and the thrombus has formed. Let's discuss various types of ischemic heart disease first, starting off with chronic stable angina. The definition of chronic stable angina is that it is a symptom complex resulting from the imbalance between oxygen supply from blood and the oxygen demands of the myocardium. So if you're not able to deliver enough blood, we get our oxygen, remember, through oxygenated blood, then the myocardium is going to be starved for oxygen. You're going to have ischemia developing. That's why we call it chronic ischemic heart disease. So in this particular case, you have an imbalance between oxygen delivery and oxygen demand. So the etiology and pathogenesis of chronic stable angina could be the fixed stenosis. Well, you can't deliver enough blood, oxygenated blood, because you have an arthroma, a plaque. That is the most common etiology in the heart itself. So one of the coronary arteries, you have a plaque. Let's hope it's a stable plaque, but because you have narrowed the lumen, you have reduced delivery of blood to that region of the heart, and when you have an increased myocardial oxygen demand, pain starts, right? That is chronic stable angina. It could also be due to anemia, whereby you have adequate delivery of blood, but there's less hemoglobin in the blood. That is the definition of anemia, and consequently you have inadequate supply of oxygen. It could also be that the coronary vessels are okay, hemoglobin is okay, but there's just not enough oxygen being delivered in blood because of a decreased concentration of oxygen in the arterial blood. In other words, hypoxemia. So this is a diffusion defect. There's something wrong with the lungs, either that or there's just not enough oxygen in the air. And consequently, although there's enough red blood cells, there's enough hemoglobin, the coronary arteries are okay, there's still not enough oxygen being developed. And lastly, chronic stable angina could also develop because of an increased heart rate, for example, in hypothyroidism. So the heart is overactive, so to speak, as in the case of hypothyroidism, and the oxygen supply is just not able to meet the oxygen demand. So in the case of chronic stable angina, the clinical manifestations are the retrosternal, so underneath, so to speak, the sternum, chest pain, right over there, tightness and discomfort radiating to the left jawline, left neck, left arm, left shoulder. Sometimes, very rarely, it radiates to the right, but most commonly, by far and away, and really can ignore the radiation to the right, it radiates to the left arm, left shoulder, left neck, left jaw. That's the phenomena of referred pain. We cover that in A&P, or hopefully you cover that in A&P. Other clinical manifestations of chronic stable angina are diaphoresis, nausea, and anxiety. Chronic stable angina is precipitated by the so-called 3 E's. So when you exert yourself, if you're in a very emotional state, or if you're eating a very heavy meal, the 3 E's of exertion, emotion, or eating, that can precipitate or trigger chronic stable angina. The key difference, however, of chronic stable angina versus unstable angina, as we'll see in ST elevation, myocardial infarction, STEMI or non-STEMI, is that it is of brief duration, 10 to 15 minutes typically, and most importantly, chronic stable angina is relieved by rest and the administration of various nitrate drugs, such as nitroglycerin. So sublingual nitroglycerin should alleviate the pain. Rest should alleviate the pain. If the pain is still not alleviated after several doses of nitroglycerin, if the pain is not alleviated by rest after 10 to 15 minutes, then it's no longer chronic stable angina. It has progressed to an acute coronary syndrome, which we'll be discussing next. Let's move on to acute coronary syndromes. Acute coronary syndromes, or ACS, consists of 3 different conditions: unstable angina, non-ST elevation myocardial infarction, or NSTEMI, as well as ST elevation myocardial infarction, or STEMI. We'll start off with unstable angina. The definition of unstable angina is an accelerating pattern of pain. In other words, the pain has increased in frequency or duration, or it occurs with a reduced threshold of exertion, or there's a decreased response to treatments such as nitroglycerin. Other definitions of unstable angina include angina at rest. Stable angina would not occur at rest. In addition, if angina has just started for the very first time, or new onset angina, it is automatically classified as unstable angina. Similarly, if there is angina post-MI or post-surgical procedures such as PCI or percutaneous coronary intervention or CABG, coronary artery bypass graft, then it is considered to be unstable angina. We already mentioned the fact that angina that occurs with a decreased response to treatment such as nitroglycerin is classified as unstable angina. So if the pain is not relieved by rest or nitroglycerin, it is most likely unstable angina. The other part of acute coronary syndromes are the myocardial infarctions. So myocardial infarction, or MI, is divided into ST elevation myocardial infarction and non-ST elevation myocardial infarction. The definition of a myocardial infarction is that there has to be evidence of myocardial necrosis, and that is diagnosed by a rise in the serum markers, troponin 1 being the specific serum marker that is typically monitored. Troponin is released when there is evidence of myocardial infarction, so when there is death and necrosis of the myocardial tissues, the myocardial cells, then troponin is released and that can be measured. So in addition to a rise in troponin 1, there's also has to be evidence of ischemia, symptoms of ischemia such as chest pain, arm pain, jaw pain, epigastric pain. Those latter 3 would be types of referred pain. So initially chest pain, but it can get referred to the left arm, left side of the jaw, or even towards the epigastrum. Also, dyspnea will most likely be present as well. So whatever the symptoms of ischemia are, if they are present along with a rise in the serum markers, troponin 1, then that is a myocardial infarction. Alternatively, if there is a rise in troponin 1 plus ECG changes such as the ST elevation or evidence of a bundle branch block, BBB, then that would be a myocardial infarction. Lastly, if there is a rise in troponin 1 plus evidence from ultrasound imaging so that there is reduced motility of the myocardium or something along those lines, there has to be evidence from ultrasound measurements, then that would be an echocardiogram, then that would be also considered a myocardial infarction. So a non-STEMI it meets the criteria of myocardial infarction as listed above without ST elevation on the ECG or a bundle branch block. A STEMI, on the other hand, is that there is a rise in troponin plus ischemia, imaging evidence, plus there is ST elevation or a new bundle branch block. What are the complications of a myocardial infarction? Aside from the acute phase, then these are the complications of a myocardial infarction. We're not going to go through all of them, but there's a risk of various arrhythmias, sometimes lethal, such as ventricular tachycardia, which can progress to ventricular fibrillation, or an AV block, or even atrial fibrillation. That occurs typically within the first 48 hours. There could be a risk of myocardial rupture, which is very serious and life-threatening. So that typically occurs, in this case, for left ventricular free wall rupture, when there is a transmural infarction or an infarction that occurs through all the layers, the endocardium, myocardium, and pericardium of the heart. There could be a rupture of the papillary muscle as well as the intraventricular septum. All that is very serious and would require surgical fixation. In addition, there is a risk of shock or the development of congestive heart failure. We'll talk about heart failure shortly as well. Lastly, there's a risk of post-infarct angina that we mentioned, that would be unstable angina, a recurrent MI, thromboembolism, that would be very common, as well as pericarditis. So all these are complications of MI. We'll discuss shock later on, and we'll also focus upon the risk of developing heart failure. Talking about heart failure or congestive heart failures, these days heart failure is preferred over congestive heart failure. As we'll see, congestive heart failure implies left-sided heart failure, whereby you have congestion in the lungs, but it could also be right-sided heart failure where there is no congestion. So heart failure is the term that is used these days, although even I will lapse into congestive heart failure. So heart failure is when there is decreased cardiac output. That's called low output heart failure, and that's what we're going to be focusing upon. In terms of systolic dysfunction, whereby it is the cardiac output that is mainly affected, that's typically due to injury or ischemia in the myocardium, for example, in a myocardial infarction. And that leads to thin, weakened muscle and ineffective ventricular contraction, and that results in a decreased cardiac output. In turn, we'll see that leads to increased cardiac workload, because if the heart is not pumping enough blood, decreased cardiac output, then there's going to be the fact that the heart is going to try to work even harder in order to compensate for a decreased cardiac output, and that's going to only make things worse. There's going to be increased myocardial stress as the blood returns to the heart but is not pumped out effectively. That leads to volume overload and even pressure overload. So we'll talk about that shortly. But systolic dysfunction is what we'll focus upon. Diastolic dysfunction is when there is infiltration and fibrosis. That's usually due to a genetic disorder, such as in dilated, hypertrophic, or cardiomyopathies. But in diastolic dysfunction, which I don't want you to focus upon, there's infiltration and fibrosis that leads to a thickening and stiffening of the myocardium and consequently ineffective ventricular filling, right? That you have blood pooling in the ventricles during the diastole. That's why it's called diastolic dysfunction. Also, please ignore this high output heart failure. So we'll focus upon just systolic dysfunction, mainly due to ischemia and infarction and resulting inflammation. That leads to an increased cardiac workload, which only makes things worse. That in turn activates the sympathetic nervous system and the renin-angiotensin-aldosterone system in order to try to compensate for the decreased cardiac output. What compensation occurs? There's an increase in the heart rate as well as an increase in the contractility of the heart. But all that is just going to put extra stress on the myocardium and make things worse. Ultimately, if the activation of the sympathetic nervous system and activation of the renin-angiotensin-aldosterone system occurs unopposed, that only leads to further increase cardiac workload and ultimately can lead to decompensation. Decompensation is where there is further deterioration of the heart function and ultimately the heart is unable to maintain blood circulation. So in decompensation, in terms of left-sided heart failure, we'll talk about the differences between left and right-sided heart failure, and ultimately we will see left-sided heart failure will lead to right-sided heart failure, which means biventricular heart failure. So left-sided heart failure, we'll talk about the backwards and forward effects in a second, but just to give you a summary, the forward effects is the inability to maintain cardiac output. Cardiac output is decreased because of the infarction, because of the inflammation, because of the ischemia. And that in turn leads to backward failure. Backward effects are because the cardiac output is decreased, blood is going to start pooling in the heart, which in turn means that blood is going to start pooling in the venous system. So there is elevated ventricular filling pressures, and actually that's for the right-sided, my fault. For left-sided heart failure, because the blood is not being pumped out from the left ventricle properly, blood starts pooling in the venous system as mentioned, but then it gets congested not in the venous system ultimately, but firstly in the lungs. So you have pulmonary vascular congestion. That's why it's called congestive heart failure. So we'll repeat this again in the next couple of slides. Because of vascular congestion in the lungs, you get fluid accumulation as hydrostatic pressure increases, and that leads to a variety of respiratory symptoms such as apnea, shortness of breath, fatigue, and weakness. In the case of right-sided heart failure, again, just in summary, the right side of the heart, the right ventricle, does not pump blood properly to the lungs, and hence blood gets congested or backed up in the venous system. So now you also have elevated ventricular filling pressures, but in this case you have vascular congestion in the venous system, systemic venous system, starting off with the vena cava. And as blood starts to accumulate in the venous system, you get increased hydrostatic pressure in the venous system, resulting in fluid accumulation especially in the lower extremities. So you have edema in the feet, the ankles, the legs, as well as in the liver and abdomen. You get hepatomegaly and the development of the risk of developing ascites as well, as we'll see. So we'll all do all this when we describe the clinical manifestations of left-sided and right-sided heart failure. So just in summary, let's look at the dichotomies of heart failure. Firstly, you have to compare and contrast the forward effects versus the backward effects, which we'll do. There's the right-sided versus left-sided, so we're really talking about the ventricles. If the infarct has affected the left ventricle, then you get left-sided heart failure, or if the infarct is on the right side of the heart, you can get right-sided heart failure. Systolic versus diastolic dysfunction we talked about, but really focus exclusively on the systolic dysfunction. Diastolic dysfunction can occur, as mentioned, in the case of hypertrophic or dilated cardiomyopathies. We'll look at cardiomyopathies as well. And then low output versus high output. We'll only focus upon low output. High output is increased cardiac output. That can occur for a variety of reasons. We're not going to focus upon that. The most common is low output, or when cardiac output is decreased. So heart failure is graded in terms of grade 1 to 4, and that's all based upon the ejection fraction. Hopefully in A&P you remember your ejection fraction, which is your stroke volume divided by your end diastolic volume times 100. So it really is based upon how much blood is pumped out of the ventricle. It's not 100%, right? Normal ejection fraction is about 66%, so anything above 66% is normal. Grade 1, it means slightly decreased. You can see in grade 2, ejection fraction is 40 to 60% or 59%. Grade 3, it has decreased even further, less than 40%. And grade 4, which is the most severe, ejection fraction is less than 20%. That's really serious. So, in summary, heart failure is the inability, this is the definition of the heart, to maintain a sufficient cardiac output to meet the metabolic demands of all the tissues and organs. In other words, cardiac output has decreased to a level whereby the tissues and organs are not receiving enough blood. This in turn leads to congestion of blood flow in either the systemic or pulmonary venous circulation. So if it's left-sided heart failure, blood will get backed up in the lungs. If it's right-sided heart failure, blood will get backed up in the systemic venous circulation. Heart failure is increasing in terms of the incidence rate, and it is the most common reason for hospitalization in those that are greater than 65 years of age. So amongst the elderly, heart failure is a very common cause of hospitalization. The etiology of heart failure is ischemia, so extensive coronary artery disease or a previous history of myocardial infarction, especially multiple myocardial infarction. We saw that a complication of myocardial infarction is heart failure. So ischemia is the most common cause, but there are non-ischemic causes as well, such as hypertension, diabetes mellitus, alcohol abuse, myocarditis, various vascular disease, dilated cardiomyopathy as well. That will cause systolic dysfunction. Let's just focus upon a myocardial insult, such as a myocardial infarction, that will cause dysfunction of the ventricles or alternatively impaired filling, leading to myocardial remodeling. So myocardial remodeling actually makes things worse. That's something to be avoided. The pressure overload by activation of the renin-angiotensin-aldosterone system, as well as the activation of the sympathetic nervous system, can lead to pressure overload. So especially if there is ankylosing spondylitis or hypertension, that leads to compensatory hypertrophy and eventually pressure overload and resulting fibrosis of the interstitial tissues or interstitial fibrosis. The myocardial remodeling can also lead to can also be due to volume overload due to aortic insufficiency. So these are valvular dysfunctions, and that leads to the dilatation of the heart muscle and leading to heart failure. And so both these processes can lead to maladaptive changes which needs to be avoided. As mentioned, the decreased cardiac output results in activation of the sympathetic nervous system and renin-angiotensin-aldosterone system. That leads to myocardial remodeling, and that in turn leads to worsening of the heart failure. So most treatments of heart failure are drugs that block the activation of the sympathetic nervous system, so anti-adrenergic drugs, as well as drugs that block the activation of the renin-angiotensin-aldosterone system, such as the ACE inhibitors, as well as the angiotensin receptor blockers, so ACE inhibitors and ARBs. Those drugs are there in order to, as mentioned, like the beta blockers, to stop the activation of the sympathetic nervous system, as well as the angiotensin receptor blockers or angiotensin converting enzyme inhibitors. Those drugs are taken in order to reduce the sodium and water retention, which increase both the preload as well as the afterload. And tachycardia, for example, will only perpetuate the cycle of increasing workload on the heart muscle, and that can only accelerate the eventual decompensation. So in pharmacology, you'll learn about the treatments of heart failure. Thus, these compensatory mechanisms and remodeling of the heart, which may be helpful in the short term in restoring cardiac output towards normal, however, in the long term, they're only detrimental towards the heart. So as just mentioned, the current management of heart failures is directed towards reducing the harmful effects of all these compensatory responses. You want to reduce the CNS activation by the use of beta blockers, for example. You also want to reduce the activation of the renin-angiotensin-aldosterone system by the administration of the ACE inhibitors or the ARBs. All that is to reduce the preload and to reduce the risk of myocardial hypertrophy. In addition, blood pressure needs to be carefully controlled as well, because hypertension will lead to left ventricular hypertrophy. So here's it in a flowchart form. So heart failure leads to renin-angiotensin-aldosterone system. It also leads to activation of the baroreceptor response and SNS activation, thereby increasing your heart rate, tachycardia, as well as increasing contractility. Both that is going to be detrimental towards the heart. And yes, in the short term will lead to increased cardiac output, but in the long term can lead to decompensation, the increased risk of decompensation as well. So heart failure will lead to increased heart rate, increased contractility as compensatory mechanism. It also leads to increased preload because of the activation of the renin-angiotensin-aldosterone system. And it also leads to increased workload on the myocardium, it leads to hypertrophy. All this is good in the short term, very short term, because it does increase cardiac output, but long term, as mentioned, can only increase the workload on the heart and lead to the increased risk of decompensation. Left ventricular heart failure is the most common type of heart failure, but here's the very important fact: it often leads to right ventricular failure as well. So it may start with left ventricular failure because of the myocardial infarction on the left side of the heart affecting the left ventricle, but eventually it would lead to right-sided heart failure as well. Now, in terms of the clinical manifestations, which is most important, we have to talk about the clinical manifestations of forward failure, and all those clinical manifestations in other words, the forward effects, are all due to insufficient cardiac output, insufficient cardiac pumping manifested by reduced or very poor cardiac output. The backward effects of heart failure are all due to congestion of the blood behind whichever ventricle is starting to fail. So if it's left-sided heart failure, you have congestion in the lungs because blood pools in the lungs, because remember, blood flows from the lungs into the left ventricle via the pulmonary veins. But in this case, because the left ventricle is not pumping properly, blood gets congested in the lungs. You get pulmonary congestion, and then all the backward effects of left-sided heart failures are related to the lungs. They are all pulmonary in nature. So here's it schematically from A and P. So if you have left-sided heart failures, the forward effects are all because of reduced cardiac output, reduced blood flow towards the upper part of the body, the brain, reduced blood flow towards the systemic system, the GI tract, the rest of the peripheral capillaries, etc. The backward effects of a left-sided heart failure are all because of congestion in the lungs, pulmonary congestion. If it is right-sided heart failure, if you had a myocardial infarction on the right side of the heart affecting the right ventricle, then the forward effects are the reduced blood flow towards the lung, but ultimately you'll see it's not really affecting the lungs. Yes, it will, but the effect is that you have reduced cardiac output towards the lung. But remember, where is the blood flowing from the lungs henceforth? It's flowing to the left side of the heart, and then from the left side of the heart to the rest of the body. So ultimately, the forward effects of right-sided heart failures are the same as the forward effects for left-sided heart failures, because if you're not pumping blood from the right side of the heart to the lungs and then to the left ventricle, ultimately the left ventricle is not going to get enough blood, and cardiac output is going to be reduced. So the forward effects of right-sided heart failure is all related to reduced cardiac output, just like the forward effects of left-sided heart failures are also all related to reduced cardiac output. However, the backward effects of right-sided heart failures is congestion in the systemic venous system. So the backward effects of right-sided heart failure are very different from the backward effects of left-sided heart failures. The backward effects of left-sided heart failures are all due to pulmonary congestion. The backward effects of right-sided heart failures are all due to congestion in the systemic venous system, which we'll be examining right now. So for left-sided heart failures, the forward effects are all because of insufficient cardiac output, resulting in decreased blood supply to the peripheral tissues and organs, ultimately leading to reduced delivery of oxygen and nutrients to all those peripheral tissues and organs. The backward effects of left-sided heart failures is all because of accumulation of blood within the pulmonary circulation, leading to pulmonary congestion, increased pulmonary hydrostatic pressure, and ultimately increased pulmonary edema. So they're all pulmonary in nature, the clinical manifestations, as we'll see. So here's it in flowchart form. So you have left ventricular failure because of a myocardial infarction affecting the left ventricle wall. That leads to the forward effects of a reduced cardiac output and resulting ultimately in decreased tissue perfusion. So organ functioning is going to be affected, obviously. That we already talked about, the compensatory responses, increase activation of the sympathetic nervous system, increased activation of the renin-angiotensin-aldosterone system, which leads to increased fluid retention, which leads to increased preload. So the backward effects of left ventricular failure, of left-sided heart failures, is an increase in pressure in the pulmonary vascular system, resulting in pulmonary congestion and all the manifestations that result from pulmonary congestion, including pulmonary edema. So we'll look at that shortly. Right now, in fact. So let's do the forward effects first. So the forward effects of left-sided heart failure are all because of reduced cardiac output, resulting in the organ systems and the peripheral circulation being affected. So let's try to explain all this. Fatigue is because of reduced perfusion of really the entire body, right? Including all the muscles and so forth. Oliguria is because of reduced perfusion of the kidneys. Increased heart rate is really a compensatory response due to activation of the renin-angiotensin-aldosterone system, as well as mainly because of activation of the sympathetic nervous system. Faint pulses because of reduced circulation in the periphery. Restlessness, confusion, and anxiety is because of reduced perfusion of the brain, for example. In terms of the backward effects, it's all because of pulmonary congestion and potentially pulmonary edema as well. So dyspnea on exertion, that's to be anticipated as the lung functioning declines because of the fluid buildups in the lung. Orthopnea is increased difficulty while being in the supine position compared to the upright position. And that's because most of the lung tissues is on the posterior aspect, and when the patient is lying down in the supine position, the fluid, because of gravity, tends to settle on the posterior aspects of the lung and thereby occupying most of the lung tissue, so you have increased difficulty breathing or orthopnea. Cough because of the fluid buildup. Paroxysmal nocturnal dyspnea, or PND, is when the client wakes up suddenly at night coughing away because of the fluid buildup, more so during the night. Cyanosis because of the reduced potential for diffusion in the lung, and yes, crackles in the lungs as well because of the fluid buildup or the pulmonary edema. So all those are the 4 backward effects of left-sided heart failure. They're all related to pulmonary congestion. Here's it schematically. So you start off with left ventricular failure because of myocardial infarction affecting the left ventricular wall. That in turn leads to backward effects. So you have increased pulmonary congestion, you have increased pressure in the pulmonary venous system. That leads to pulmonary edema and all the clinical manifestations we saw related to the backward effects of left-sided heart failure. That in turn leads to increased pulmonary arterial pressure, and now we will see ultimately it increases the workload of the right ventricle. So as pressure builds up in the lung, the right ventricle is going to have more difficulty pushing the blood into the lungs because of all the buildup, the congestion over here, right? And the pulmonary artery pressure increases, so it means that it's going to have, the right ventricle is going to have to pump a lot harder to push blood into the lungs. That in turn leads to right ventricular hypertrophy, a condition that is referred to as cor pulmonale. Right, ultimately, this will lead to right ventricular failure. So left-sided heart failure will eventually, given enough time, lead invariably to right-sided heart failure. Right-sided heart failure is all because of the effect on, perhaps because of left-sided heart failure. So pulmonary disorders resulting in increased pulmonary vascular resistance, which is left-sided heart failure, leads to a high afterload, which in turn, as we mentioned on the previous diagram, leads to cor pulmonale, which is right ventricular hypertrophy. And eventually, it leads to right ventricular failure due to the pulmonary hypertension caused by the pulmonary congestion. So in right-sided heart failure, the forward effects are all because of the low output to the left ventricle. So the forward effects of right-sided heart failure is exactly the same as we'll see compared to the forward effects of left-sided heart failure. They're exactly the same, and that's because it's all due to reduced cardiac output. The backward effects of right-sided heart failures are all due to congestion in the systemic venous system. So firstly, remember the first bullet point over there is about the etiology. What can cause right-sided heart failure? Well, it could be a myocardial infarction that has affected the right ventricular wall. But even more commonly, right-sided heart failure develops because of left-sided heart failure. The left ventricle is much bigger than the right ventricle. So if there is a myocardial infarction, it's more likely to affect the left ventricle compared to the right ventricle. That's not to say that there are no right-sided myocardial infarction. They are, but it's more commonly on the left side. So you start off as a complication of left-sided myocardial infarction. You start off with left-sided heart failure, but then that could eventually progress to right-sided heart failure. So the etiology of right-sided heart failure is left-sided heart failure. Another etiology of right-sided heart failure is a myocardial infarction affecting the right ventricular wall. So you have right-sided heart failure. The backward effects are all due to systemic congestion in the venous system. And the forward effects are identical to the forward effects of left-sided heart failure or left ventricular failure. It's all because of decreased tissue perfusion for the brain, for example, to the kidneys, for example. And now you have appropriate in the short term, but inappropriate in the long term activation of the sympathetic nervous system, resulting in tachycardia and increased workload, as well as activation of the renin-angiotensin-aldosterone system, which only leads to increased fluid retention and increased workload on the right ventricle as well. So you have increased ventricular preload. So if you look at the forward effects of right-sided heart failure, they are completely identical to the forward effects of left-sided heart failure, including fatigue, and then restlessness, confusion, anxiety because of reduced perfusion to the brain, oliguria because of reduced cardiac output to the kidneys, tachycardia as a compensatory responses, faint pulses because of reduced cardiac output to the periphery. In terms of the backward effects of right-sided heart failure, they are completely different compared to the backward effects of left-sided heart failure. So here it's all about increased congestion in the systemic venous system. So now as blood gets backed up in the venous system, systemic venous system, you have all the highly vascularized organs, they will become enlarged. So you'll have hepatomegaly because of the fact that the liver receives a lot of blood, especially from the portal system, so hepatomegaly occurs. Splenomegaly because the spleen receives a lot of blood, the red blood cells are all recycled in the spleen, so as blood gets backed up, you're going to have splenomegaly. Asides because of blood getting backed up in the GI system, resulting in increased hydrostatic pressure in the abdominal region and more fluid exudation, and now fluid builds up in the peritoneal cavity, leading to asides. Anorexia, perhaps we can explain anorexia because of the asides. As pressure builds up in the abdominal region, they're going to put pressure on the intestines, pressure on the stomach, you're going to have a reduced appetite. Subcutaneous edema, or really edema in general, I would omit the term subcutaneous. So edema in the periphery, especially edema in the lower extremity, in the legs, in the ankle region, all that is because of increased hydrostatic pressure in the systemic venous system. In addition, you're going to have jugular venous distension. That's probably one of the signs that is more easily assessed, and that's because of venous congestion as well here in the upper part of the body. So blood coming back from the head as well as all the regions above the heart, that's going to get backed up because of the right-sided heart failure, and the jugular veins are going to get distended. So here are all the backward effects of right-sided heart failure. Here's it systematically in diagrammatic form. So you have right ventricular failure. Why? Because of a myocardial infarction in that region that has affected the right ventricular wall, or alternatively because of copulmonary due to the fact that there is left-sided heart failure. Regardless, now you have right-sided heart failure. What does that lead to? That leads to blood backing up in the systemic venous system. Firstly, it leads to jugular venous distension. Then it leads to increased pressure in the vena cava. That leads to increased pressure in the systemic venous circulation, leading to congestive I'll add splenomegaly. So hepatomegaly, you combine with splenomegaly, you get hepatosplenomegaly. That also leads to increased pressure in the abdominal region, leading to asides, as well as increased fluid exudation in the lower extremity, leading to edema in the legs, and especially around the ankles. That's referred to as pedal edema. Here's an example on the left side of lower extremity edema due to right-sided heart failure, and the next photo illustrates the same patient after treatment. So after treatment, which includes diuretics, you have reduced fluid buildup, as well as beta blockers, as well as renin-angiotensin aldosterone system inhibitors, such as the ACE inhibitors or ARB. Now you have reduced fluid buildup in the lower extremities, right? So you can see here the fact that there's a lot of edema, including this dependent edema over here. So you press down upon it and you can see the indentation due to the extreme fluid buildup in the lower extremity. And that's all because of increased venous pressure in the lower extremity due to right-sided heart failure. This are the backward effects. So it typically starts with left-sided heart failure, then it can progress to right-sided heart failure. Occasionally, right-sided heart failure will develop first because of a right-sided myocardial infarction. But right-sided heart failure will eventually lead to left-sided heart failure, just like left-sided heart failure eventually leads to copulmonary and right-sided heart failure. How does right-sided heart failure lead to left-sided heart failure? Because of reduced cardiac output. So from the right ventricle, you get blood being pushed to the lungs and then to the left ventricle. But if you have right-sided heart failure, less blood is being pushed to the lungs, which means that the left ventricle is getting less blood, which means that the left ventricle is also going to become ischemic, resulting over the long term in left-sided heart failure. So regardless of whether it starts off with left-sided heart failure or right-sided heart failure, eventually biventricular heart failure develops over there. And that means reduced cardiac output. That also means pulmonary congestion due to left-sided heart failure, as well as systemic venous congestion due to right-sided heart failure. In other words, you have the backward effects of left-sided heart failure, you have the backward effects of right-sided heart failure, and you have the forward effects of both left-sided and right-sided heart failure. Remember, the forward effects of right-sided and left-sided heart failure are identical. It's all because of reduced cardiac output. So in summary, for heart failure, please look at the etiology for both left-sided and right-sided heart failure. Compare and contrast the left-sided and right-sided heart failure, especially in terms of the forward and backward effects. So in other words, the clinical manifestations. So in summary, for the part 2 of the cardiovascular disorders, please remember that pathophysiology encompasses the etiology, the risk factors, especially the modifiable risk factors, as well as the pathogenesis, or how does the disease develop. But please, 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 most importantly, focus upon the clinical manifestation, especially, for example, as we spoke about the heart failure. The focus should be on the clinical manifestation of both left-sided and right-sided heart failure, both the backwards and the forward effects. And so not just for heart failure, but for all the other diseases, disorders, and conditions that we covered in part 2 of Unit 1. Always remember that you will only be assessed upon the diseases, disorders, and conditions that are listed in the learning outcomes, in this case, of Unit 1. If you have any questions whatsoever, please contact me via email, or alternatively, whoever your other instructor is for this particular course, if you require any clarification or assistance. Our next lesson is going to be part 3 of the blood and cardiovascular disorders. We're going to be specifically focusing upon shock. See you then. Thanks. Bye.